right, everybody. Looks like we're right at 8 o'clock, so I will get started. I will do my best to monitor the questions as we go. I apologize if I don't see it immediately, but feel free to chime in and ask any questions that you have. I'm going to talk a little bit today about a very broad topic within laryngology. So inflammatory and systemic disease of the larynx. What does that mean? That means things that you see in clinic that aren't the common things. They aren't the phonotraumatic lesions. They aren't the cancers, the airway stenosis necessarily. These are things that are a little bit more of the zebras in laryngology. And yet, if you put all those zebras together, you have a herd. And there are a lot of patients who will come in with very weird things that present in the larynx that need your attention, specifically your diagnosis and then any sort of therapeutic treatment ongoing. So this is what we're going to talk about today, and we'll cover all the pictures that you see here as we go. Here we go. I have no disclosures, no conflict of interest. I will say this is for personal education purposes only. Please ask questions, as I say. I think the format is typed questions, so I'll be monitoring that, the Q&A area. I won't be able to talk about all of the inflammatory things that go on in the larynx today, but hopefully this will give you a framework for how to think about this. And we can provide you some key examples, specifically cases that will give you a framework with which to think about inflammatory disease in the larynx. So a lot of you may ask, and I know a lot of my residents have asked, do we really need to talk about this? Most of the conditions we're going to talk about today are rare, and most of the conditions are non-surgical. Often we get involved for biopsies and things like that, but many of these systemic diseases are best treated with systemic therapy. But I would argue to you that ENTs, and specifically laryngologists, are uniquely positioned to direct multidisciplinary care for a lot of these folks, especially the ones who present specifically with throat complaints, because we kind of sit at the center of this group of physicians and healthcare providers like SLPs, rheumatologists, ID doctors, pulmonologists, who may really not be able to see what we see, but we need their help in terms of coordinating treatment for these folks. Additionally, you see the little picture of the canary here. I think that's a canary. The larynx is often the canary in the coal mine, so to speak, for systemic diseases. A lot of these weird things that can present in the larynx first, and we may be the first line in terms of diagnosis, which is what makes this a lot of fun, and in general, what makes laryngology a lot of fun. And then finally, a lot of what you're going to see today mimics carcinoma. So when you look at the larynx of a person with some of these systemic inflammatory diseases, you will see really weird stuff that needs to be ruled out from a cancer perspective. So this is the general outline. We're going to talk a little bit about background about inflammatory disease in general. We'll do some cases, and then we'll get to conclusions at the end. Keep this picture in mind. This is how I like to divide the things we're going to talk about today. So we're going to talk about some immune-related things, that is antibodies and other sorts of hyperreactivity conditions that can affect the throat. Deposition diseases, we'll talk about those in detail. Granulomatous diseases, my least favorite of all of these because it's sometimes quite hard to diagnose and everything looks the same. Infectious, viral, bacterial, fungal. We'll talk less about this today. You could do a whole other talk about infectious laryngitis, but we'll kind of leave that off the docket for today. And then finally, your grab bag of others. So angioedema, caustic ingestion, radiation changes, which can all lead to inflammation. And finally, LPR, which we will talk about just a little bit. So we all remember from medical school the inflammatory cascade. This starts with a number of different cell types, and those cell types move in over different periods of time. So imagine you have an injury to your tissue. The first thing you'll see is mast cell degranulation, histamine release, which starts an allergic response, if this is an analogy, but can also start the inflammatory cascade, which then brings in neutrophils over a period of the next few hours, which leads to early phagocytosis, as well as coordination of the rest of the inflammatory response. Monocytes arrive a little bit later, and again, these start to initiate that next step, the cellular and humoral immunity from T and B cells. So that's the cellular, like the T cells, which actually do phagocytosis and kind of organize the rest of the response, as well as the B cells which produce antibodies, which will then further tailor your inflammatory cascade. Remember that we think about inflammation in two different ways, and we see both of these in the larynx. So acute phase, which involves vasodilation, permeability of those vessels and chemical mediators. So if you picture this little diagram here, the top left corner of that shows that there's some permeability of those blood vessels, which allows those white blood cells to go to the surrounding tissues. And that can go through a number of different passes. Either that can resolve, so that to the right side of the screen where everything seems to heal itself. It can result in chronic inflammation, that's at the bottom left of this little diagram, which leads to further creation of these fragile blood vessels, further infiltrates of cells, which will continue for weeks, months, years, and then can finally lead to fibrosis at the bottom right of the screen here, which can lead to scarring and then changes the function sometimes of the larynx. It's important to try to differentiate between which of these things are, which of these processes are chronic and which of them are acute. In this sense, inflammation in the larynx can be a protective response. It can get rid of injuries and pathogens, but it can also lead to damage of the tissue, specifically scarring, fibrosis, which in the setting of vocal fold mucosa is a quite important thing to consider, because it can lead to scarring and alter function, not only in terms of voice, but in terms of airway concerns, swallowing concerns, etc. So when we talk about inflammation in the larynx, what tissues are actually affected? So here's a picture of the larynx without actually any of the epithelium and mucosa. It's kind of just showing the underlying ligament, muscles, cartilaginous structures, but it's helpful for visualizing. So if there were mucosa here, you could think of that as one of the main targets of inflammation. Certainly, as you all remember, the mucosa is made up of the epithelium, which is a 25 to 50 micron thick layer that overlies the subepithelium. Subepithelium here in the larynx, as you remember, is the superficial lamina propria, intermediate and deep layers of the lamina propria, and beneath that, as you all know, is that muscle, which is pictured here, that vocalis or thyroarytenoid muscle, vocalis being the more medial aspect of that. Other inflammatory targets in the larynx, nerve tissue. Certainly, you have little tiny blood vessels around the nerves, which can lead to, when there's vasculitis, that can cause damage of those nerves. And there can actually be direct neuronal inflammation as well, which can be affected by this. Muscle can be affected. Certainly myositis does not spare the larynx. Remember, there are special muscle types in the larynx. I won't say they're unique to the larynx, but you have to think about what types of muscle are there. And we tend to have this kind of this red meat muscle in the larynx, so to speak, things that have to work a lot at a low level all the time, things like breathing, swallowing, so they are susceptible to specific types of myositis. And then finally, inflammation of joint spaces. As you know, the cricoarytenoid is a synovial joint that, just like any other synovial joint in the body, like your shoulder, like your knee, can become inflamed, can become scarred, leading to joint ankylosis, and we'll talk about that in detail. Looking for questions. I don't see any yet, so we'll continue moving on. One of the frustrating things about these particular set of diagnoses are that symptoms tend to be nonspecific. In fact, this is one of the frustrating things about outpatient laryngology in general. People come in pointing to their throat or saying, "Doc, voice hurts," or "it hurts to speak," or "my voice sounds funny," or "I'm coughing," or "I'm clearing my throat." So all of these different symptoms that we see so often are not necessarily specific to any of the diagnoses we're talking about, but should at least pique your interest in terms of getting a good look at the larynx to try to figure out what's going on. So we're going to jump in now with cases. So we're going to start with the case of a 26-year-old woman. She's a soprano. She sings semi-professionally. She has a day job working in a call center, but also sings semi-professionally on the weekends and makes some money off of that. With what she described as a raspy voice, this has been going on for months, as she describes it. And she says, specifically, she has difficulty singing the high notes in choir practice, and more recently has started to notice that it's affecting her speaking voice. That's what she describes as raspy. No real past medical history. She's been seen by a few other physicians in the area, and they've told her that she has LPR. We're going to go.
My throat, whether
is her voice. I don't know if the quality of that came through, but she says she has trouble singing high and singing low. When you listen to her voice, you can hear a significant amount of vocal fry. There is some roughness there, and certainly some strain as well. So trying to evaluate her voice, you say, well, I think this warrants laryngoscopy and stroboscopy. Here we have her phonating. We're looking at gross anatomic features and also at mucosal wave. I won't tell you my thoughts yet, so I want you to develop your own thoughts. Tell me what you, or think about what you think this represents. So I would say, just to review that stroboscopy, I know it's probably not the full 120 frames per second coming through Zoom, but she has, certainly there is a mucosal wave present on both sides. It's relatively symmetric. It is slightly diminished in amplitude. There's not any phase asymmetry that you can see, and she does achieve relatively good closure. Here on the halogen light, you can see that this actually brings things out a little bit better. If you look at the left picture here, you can see in the mid-membranous region of the vocal fold, on both sides, there appears to be a somewhat perpendicularly oriented subepithelial something or other. I would call this a lesion. It does not appear to be epithelial, but does appear to be in the subepithelial space. With a surrounding blush of erythema. You see how it's a little bit red around each of these little nodules, we'll call them for now. And that the appearance of this is not typical for a regular nodule, which is typically on the medial surface of the vocal cord and kind of looks rough and thickened. This seems to be coming in a perpendicular fashion across the superior surface of the cord. So it's certainly interesting. Any thoughts from the group as to what this could be? Looking at question and answer. We have someone raising a hand. Let me see if I can figure out how to figure that out. One second. I see you there. I'm going to figure this out. Well, I apologize. I can't figure out how to get... here we go. Someone. Bamboo nodules. Thank you, Dr. Yu. Indeed. That is a very good call. These are bamboo nodules. We're going to talk about what that means in just a second. Think about now, what do we need in terms of other workup? What do we do in terms of next steps? Does this patient need steroids, surgery, more LPR therapy? Well, we think these bamboo nodules are related to, say, a rheumatoid process. And in this patient, we referred her to voice therapy, which is an appropriate thing for almost all benign vocal fold lesions, at least to start, especially when patients are having these complaints with both speaking and singing. And then after that, we didn't give her any steroids or anything like that. She didn't notice any significant improvement after voice therapy, so she ended up having a surgical procedure for this. And I'll show you some video here. Here you can see us doing a subepithelial saline infusion in order to try to hydrodissect a little bit. You can see here using fine microlaryngeal instruments, dissection, careful microflap dissection around this lesion. Grabbing the lesion here, you can separate it from the underlying superficial lamina propria. Again, trying to preserve as much superficial lamina propria as possible, because this is what this soprano needs long term. And then a completely non-evidence-based steroid injection at the end for healing, which is part of our practice, but not everyone does that. This is what the pathology shows. You can see here on this H&E stain that there's an inflammatory infiltrate there at the black arrow. These little tiny inflammatory cells can be seen to be infiltrating the tissue. And then where you see the blue arrow up top, this kind of eosinophilic pink amorphous calcific debris with, and I relied on my pathologist for this one, degenerated collagen spherules is what they're calling this, was consistent with this bamboo nodule. So rheumatoid nodules or bamboo nodules was the diagnosis here. Just for follow-up, we certainly did ask this person to see a rheumatologist who said, you got nothing going on. And then she went home and was fine for a year until she developed some wrist swelling and was thereafter diagnosed with seropositive rheumatoid arthritis, started on medical therapy, so disease modulating drugs, and is now doing well. So rheumatoid arthritis, as we all know, is a chronic inflammatory autoimmune disease. It primarily affects joints. You can see here in the picture it affecting the hand joints. There's an X-ray showing that's a severe deviation of some of the phalanges. It affects 1 to 2% of the world population, diagnosed at a mean age of 40, and the female to male ratio is 3 to 1, so many more women than men, as is true for many autoimmune conditions. And diagnosis is made with a bevy of serologies. So rheumatoid factor, anti-CCP, ESR, and CRP rather are non-specific but often used. Someone has mentioned in the question here, did you do bilateral surgery? Indeed, bilateral surgery was done here. I just shortened this for the case presentation. All right. Moving on from there. So how does rheumatoid arthritis affect the larynx? Again, those same key targets. So the vocal fold can be affected. That is the mucosal tissue itself. You can see nodules, as we saw in this patient. Sometimes this is associated with amyloids. You can see amyloid deposits here. You can see changes to the nerve. This is less common, but it does happen. So degeneration of the vagus and the RLN can happen due to vasculitis of the vasa nervorum. Again, that's the network of blood vessels that surround the nerves in the larynx and elsewhere. Also, you can see degenerative changes. This is not something we commonly diagnose because it would require a muscle biopsy, but certainly has been described in postmortem studies. And then finally, and this is a very significant one, is changes to the cartilage itself, to these cricoarytenoid joint can be seen in rheumatoid arthritis. And we'll talk specifically about several cases of this in just a second. So how common is this? Rheumatoid arthritis is fairly common, 1 to 2% of the world population, but how often does it present in the larynx? The answer is it might be more common than you think. If you look at all the studies that have been done on this back from the 70s until now, that have been done with a number of different modalities, that is looking at pathology, post-mortem studies, CT imaging, looking to see if there's any signs in the joint space in particular, or in the mucosa itself, to see if there's any rheumatoid arthritis findings there, or with direct laryngoscopy, or by analysis of symptoms. You can see that there's first of all, a wide variety of incidents here. Anywhere from 14 to 88% of patients with rheumatoid arthritis will have some sort of laryngeal manifestation, which to me seems actually higher than you might expect, because this is not necessarily a common population you see coming through your clinic, but it does indicate that there may be more going on in these patients than we otherwise suspect. A couple more questions about these nodules. What are the chances of those nodules returning in rheumatoid arthritis? High, and we'll talk about that in just a second. So these nodules, these bamboo nodes, people describe them as bamboo nodes because they look like these joints between the different segments of bamboo. Risk factors include seropositive RA, as our patient had, high vocal use, so phonotraumatic concerns. GERD has been associated with these, although GERD is not causative of this, neither is LPR. Treatment, so this is what the questions revolved around. Treatment is typically done with steroids that can be either locally injected, and again, this is kind of an anecdotal thing. It's not been widely reported in the literature. Voice therapy is certainly a mainstay for most benign vocal fold lesions, and they can be removed surgically. I will say what you saw, this surgical excision that we did here, is certainly not the most common thing. It is usually more of a voice therapy and steroid injection, and then finally excision if absolutely necessary, because they do tend to come back. I showed it just because I thought it was an interesting case. So in pathology, these things can look like simple nodules grossly, but they do not look like nodules under a microscope, because you see this inflammatory infiltrate, those degenerated collagen spherules, all that stuff that we talked about already. Recurrence is common. And again, here's a picture of that pathology. Interestingly, these nodules can appear before other manifestations of rheumatoid arthritis. So it's important to take a look in these folks. And again, some of the specific characteristics of them, They're at the mid-membranous point of the vocal fold, just like many phonotraumatic lesions. Their lung axis does typically appear to be perpendicular to the vocal fold main axis, so kind of an abnormal or a funny-looking presentation underneath the surface there. There's an inflammatory blush, as you saw in this patient. It looks a little bit red around that white, cream-colored subepithelial deposit, and they are associated with autoimmune diseases, RA, SLE, Sjogren's, etc. Next, another aspect of rheumatoid arthritis that we have to think about is affecting the joint, and this is the other main one that you'll see in our laryngology office. I'm just going to check to see if there are any other questions about the nodules. Do you do anything differently for these patients post-operatively in terms of systemic steroids? I let the rheumatologist guide the steroid plan. So post-operatively, I don't do anything specific, but I would talk to the rheumatologist ahead of time to make sure there's nothing else they would want to change in terms of the steroids that they're on. So the cricoarytenoid joint, as you know, is this synovial joint that can be affected by rheumatoid arthritis. Just like any joint, it can be affected by synovitis, that is inflammation of that joint space, the lining of the joint space. In particular, that lining of the synovial space produces the fluid that is in the joint. You have proliferation. This is a specific term that means you have abundance of that lining. It can lead to excess fluid, it's effusion. Pannus formation, this is this kind of gummy material which will then fill the joint space. Obliteration of the joint space, leading to ankylosis, that is a long-term fibrotic scarring process that will happen in this joint, which will lead to reduced mobility. As you know, reduced mobility in the cricoarytenoid joints is a problem. This can present in up to 25% of patients with systemic rheumatoid arthritis. That's from Bill Montgomery's studies done in the past. Patients typically present with non-specific symptoms, but then stridor comes late. So when the ankylosis is set in, they'll start to present with severe stridor. Asymptomatic. Many patients will probably have some degree of this, but not be symptomatic from it. And I have several patients who don't really notice any breathing problems, don't have high breathing demands, and so unless they're really stressed and really using their accessory muscle breathing, they won't really notice any changes, and that's been demonstrated in some post-mortem studies as well. If there is an acute flare of cricoarytenoid joint inflammation, you might see some redness and swelling of the arytenoids, some edema of the cords, but more commonly you'll see this in the chronic patient, thickened mucosa of the arytenoids, glottic chink, bowing of the cords, and then fixation of the arytenoids. Treatment for cricoarytenoid joint ankylosis. Certainly, tracheostomy is always an option, but typically these days we do things endolaryngally. Here you can see a picture of actually a patient I did not too long ago who had a transverse cordotomy, but also resection of a significant portion of the cartilage back here in order to widen the glottic area. You can see that the endotracheal tube now has a lot more space here, and this patient is doing fine, I think 9 months out after this procedure. Doesn't have a normal airway by any means, but does have enough of an airway to breathe. We can also think about steroid injections in these patients, usually as an adjunct, but some people will use it as a primary treatment. And then finally, medical therapy. If I can harp on anything during this talk, it's that systemic diseases require systemic therapy. So having your rheumatologist involved early is certainly helpful, unless you're in the mood to start giving disease-modifying agents and biologics in your practice, which come with their own set of risks. So again, lessons here, because I spent most time on this one because I think it's a good case study for all of these things in general. These inflammatory presentations in the larynx may be more common than we think, but they are not always going to be symptomatic. The larynx can be a harbinger for future systemic disease, so important to think about, as we saw in our patient. She was later diagnosed with rheumatoid arthritis. There can be many sites of involvement in the larynx, so you have to look carefully. And then finally, the surgical role here are for things like biopsy and then airway management, debulking. But as you know, surgery won't fix rheumatoid arthritis, right? It does not treat the systemic disease. So we think of ourselves as helpful in this, but not necessarily curative. So again, this applies to many inflammatory conditions. So we'll move on to a different case. I will just look at the question and answer area right now. Standard blood work. Yes, so we talk about blood work for inflammatory things. I do pretty much the same thing for everyone, which is broad. If it hasn't been done by the rheumatologist already, CBC with differential, ESR-CRP, And then my classic inflammatory things include ANA, ANCA, RF, ACE, and I kind of send all of those, just a standard room panel. I don't send things like anti-CCP, anti-double-stranded DNA. If it's getting to that point, I really do need someone who can actually interpret all those things in detail. Because if I order them, I have to read them. And I think that's probably better done by one of your rheumatology specialists. All right, so next case. This is a 69-year-old man. History of multiple things, has hypertension, pulmonary hypertension, asthma, has a history of sarcoid. Who's noticed a rough and strained voice for about 2 months. I started an inhaler, started a PPI. Nothing really seemed to help. This is a still picture here, which the laryngologist, one of my colleagues who saw this patient, described as multiple yellowish submucosal lesions along the vocal processes bilaterally and the posterior glottis. And at this point, the patient had essentially mobile vocal cords that on stroboscopy had relatively good vibration, but certainly some aperiodicity and definitely some roughness perceptually in the voice. So at this point, you can think, well, this is concerning. I would likely biopsy this because I'm not sure what this is. Now, is this likely to be a cancer? It's not. It's bilateral. It doesn't have that kind of aggressive appearance. Again, if you see things that are multifocal throughout the larynx, usually that's less likely to be cancer, but certainly we do see multifocal cancer as well. So the patient was offered a biopsy and said, no thanks. And then came back. This is a very choppy video, unfortunately. 1.5 years later, and had this examination. So now you can see, this is actually the patient trying to take a deep breath in. You can see that this kind of granulomatous inflammatory tissue in the back of the larynx is now fused from one vocal process, from one aspect of the posterior larynx to the other, in that intra-erythenoid space with progressive fibrosis. At this point, the patient had inspiratory stridor, and the cords were not moving much at all, and the voice was not good at either. CT was done, which did show bilateral hilar lymphadenopathy, extensive and thought to be related to the previous sarcoid. So the diagnosis in this case was kind of tipped by the previous history of sarcoidosis. And the doctor at this point said, well, this must be sarcoid. We do need to take care of your airway now, and we'll get a biopsy at the same time. So they're booked for surgery. Unfortunately, they presented with worsening stridor, and before they even presented to us, it ended up being intubated successfully through this, transferred to our institution, and then underwent an emergent surgery. So it certainly had an incisional biopsy, which was sent off, a balloon dilation, transverse cordotomy, again, where you cut into the posterior aspect of the vocal fold and remove some of that cartilage if you think that's appropriate, of the arytenoid as well, and then a Kenalog injection. I will say that description doesn't adequately describe. There was a pretty significant debulking of the posterior glottis as well in this case. This is what the pathology showed. So this is your H&E stain, which shows multiple granulomas here at the black arrows, which are, again, these organized balls of monocytes, macrophages, which kind of wall off from the surrounding tissue, indicating that there's some inflammatory immune response here. Here's that circumcised granuloma. Looking at closer, again, you may be asked to look at things like this on your oral board, so good to have a picture of what granuloma looks like. This is the fibrinoid necrosis at high power. You can see with that eosinophilic material. And then here, as our pathologist noted, there is acid-fast bacilli totally everywhere, he described, throughout this tissue. So this kind of changes the picture. You're thinking granulomas, yes, sarcoid, yes, but now we see acid-fast bacilli everywhere. That's a little bit of a different story, and my gosh, I'm glad we sent this off for this kind of testing, because that certainly can kind of change your diagnosis. So this patient was eventually diagnosed with, excuse me, I should say, we talked about that, Mycobacterium chimera, so part of the MAC family. So in this case, in a patient with pre-existing sarcoid, who had sarcoid-like looking granulomatous lesions of the posterior larynx, was actually diagnosed with a MAC infection. So again, this kind of demonstrates the importance of the biopsy and our role in that. So this patient underwent long-term antibiotic treatment. Here you can see a very terrible video. I'm sorry that it's so fuzzy. There's a lot of mucus on the camera or something. of what things look like afterwards. He does have restored cord mobility. That intra-arytenoid scar band is present, but certainly much better, and everything resolved after that. So mycobacterial infections have low incidence in general, but increase significantly in the HIV area, and are associated sometimes with pulmonary disease, but not always. You don't necessarily need to have a MAC infection of the lungs. The mechanism of laryngeal involvement is thought to be either primary inoculation by bacterium or secondary inoculation from infected sputum. Granulomatous disease, again, this is another one of those big categories of inflammatory disease. We call it the great masquerader because things like tuberculosis can mimic carcinoma. They can look like a lot of different things. And tuberculosis is, again, not something we see commonly here. That's another mycobacterial infection, of course, but it's something we have to consider in these cases. TB in particular can present as one of 4 different types of lesions. That is non-specific inflammatory lesions, polypoid lesions, white and ulcerative or ulcerofungative lesions. And these last 2 are the ones that typically will present in more acute cases and cases with active pulmonary disease. So thinking a little bit more about TB, again, you need your DL biopsy or SML biopsy. You need to look for acid-fast bacilli, and you need to look for these granulomas. And finally, need to rule out carcinoma. The workup includes imaging, of course, and then involvement usually with an ID professional to help with antibacterial agents. So other sorts of granulomatous disease, in the patient we were thinking about here who had sarcoid, we were thinking this could have been sarcoid. Again, sarcoid usually presents supraglottic. Here is pictured a classic inflammatory turban epiglottis, as we call it. Here you can see that this patient's epiglottis looks like it's certainly inflamed, fusing to surrounding tissues. That inflammation extends to the area epiglottic folds on both sides as well, which can be quite problematic. And is often very frustrating for patients because they don't really know why this has come on, and many of the treatments we have are not perfect. And finally, testing for this is non-specific. So it really requires a lot of physicians putting their heads together to say, well, I think this is sarcoid, and certainly have a number of patients who have this kind of undiagnosed chronic granulomatous disease of some sort, which everyone kind of puts into the sarcoid category. This can be a very frustrating thing. Laryngeal involvement in sarcoid is anywhere from 3 to 6% in the reported literature. But when it occurs in the larynx, it's often isolated. So you'll see this patient, send them off to your rheumatology colleagues, and they'll say, no other problems anywhere else. It's exclusively a laryngeal problem. The infiltration that you can see from sarcoid is classically in the epiglottis and then the erythenoids, AE folds and false focal folds. Much rarer to be infraglottic or in the paraglottic space. And it can present with unilateral vocal fold paralysis if you have that bulky mediastinal hilar adenopathy. So this is where multidisciplinary evaluation does help. This here pictured on the right is a lady who came to my clinic with not really the chronic granulomatous appearing type of sarcoid, but this is more floppy, redundant tissue, which was causing her airway obstruction, which we had to remove. On pathology, you'll see non-necrotizing granulomas. Here are some pictures of that on the left, sarcoid, which is the non-necrotizing, versus TB, which is necrotizing, and then a picture in the canine of what this can look like when it really grows to a large size in the larynx. Management, certainly there can be spontaneous remission. This does happen. Medical management is much more common, using things like steroids and other disease-modifying drugs. Steroid injections have been described with varying degrees of success. It remains an option that you should keep in your armamentarium. It is not necessarily going to fix things permanently. Again, this is one of those things where we can help to modify the disease, but can't cure it. And then surgery is really indicated for excision, dilation, things that are affecting the airway and the voice. But if they're getting good response to systemic therapy, we don't typically intervene. Here's some pictures of, on the right side, a supraglottic procedure, a pepper-pot supraglottoplasty, which is done in order to shrink some of this tissue. Again, this is a patient who's a 26-year-old who had a pulmonary sarcoid as well as laryngeal sarcoid, where we wanted to really shrink wrap some of the tissue overlaying the erythenoids just to give her a larger airway. And that typically will help. You also may just excise some of this tissue, which can help. Let's move on to the next case. Let me just look at the question and answers here. Nothing new. All right. We're going to move on to our next case. So this is a 66-year-old man who was admitted for a myocardial infarction, had hoarseness after his extubation. He denied dyspnea, dysphagia, weight loss, has some real bad things going on in terms of past medical history, bad heart failure, cardiac disease, and also gout. He's not healthy. Here's a picture of the office exam. Does anybody have any thoughts, any descriptions of this that you can give me in the question and answer section? Because I think I'm probably best equipped to look at that. Any thoughts about what this could be? I'll describe it while you're thinking. It looks like there are lesions on both the left and the right vocal fold. This is a still image, of course. You can see that there appears to be a chalky-looking material of the left vocal fold that appears to be epithelial and is likely subepithelial in nature as well. And on the right side, there's also something that looks quite similar. I imagine if we had a stroboscopy, which I'm not going to show you today, that there would be some impairment of that mucosal wave. I see some, Robert has suggested fungal laryngitis, certainly a great consideration for any white patches in the larynx. And for a sick patient like this, you're thinking they're probably on an inhaled steroid, right? And when that inhaled steroid goes down on its way to the lungs, a lot of that deposits on the vocal folds. And so I can't tell you how common it is for me to see a fungal laryngitis. That is a great thought. This patient was treated with antifungals, but no resolution. A thought from Phoebe is this could be related to his gout, which I told you about. Another interesting thought. Certainly that is not a common thing to see in the larynx, but it's possible. Moving on here. A biopsy was done in the office. We can do a lot in the office, as you all know. This is a low power H&E slide showing amorphous eosinophilic material. Not very cellular, as you can see. Negative Congo red stain, as you all know, that's important for amyloid. Another consideration here. Unstained slide showing needle-shaped birefringent crystals, which is consistent with gout. So very uncommon, not probably the most likely thing here. I would have thought fungal laryngitis as well, but certainly something we have to consider. So gout, as you remember, is a deposition disease. You can see here pictured in this little cartoon from a long time in the past how the patient with gout, which is the patient all the way on the right, is depicted. Gout affects a lot of the joints, so in the feet, the hands, it can give you these deposits all throughout, and it's associated with excessive alcohol use. So this patient is drinking punch, as you can see. It's a defect in the metabolism of uric acid, as you'll remember, and it can result in inflammation and deposits all throughout the body of these monosodium urate crystals. Affects the synovial fluid, but also the skin and the cartilage. Extremely rare in the larynx. It can affect the glottis, the supraglottis in the cricoarytenoid joint, and can rarely present with airway obstruction. Importantly, it can look like fungal laryngitis, but also carcinoma. Again, I'm going to harp on this point again. Really funny things in the larynx, you kind of have to rule out cancer. And so I would say that in something like this, you should be seriously considering a biopsy. Typically, the gout, when it's diagnosed, is managed medically, but can be managed surgically. This is one of my colleagues doing a KTP laser ablation. I think it's going to play the full thing. This is kind of the first described use of KTP laser in the office for the treatment of gout. He says it worked. I would say it's not a common treatment, but hey, rare disease, think outside of the box. It's not unreasonable for a guy who can't go to the OR because he's a little too sick for that. Remember that gout is a deposition disease, but we also have to think about other deposition diseases. When you see deposits of material like this in the subepithelial space, amyloid should come up. And again, our pathologist did stain for this. This is something we were thinking about. Amyloid, as you remember, is an idiopathic, often idiopathic dysproteinemia, which deposits these fibrillar sheets of what we call beta-pleated sheets in the tissue. And interestingly, these are usually non-reactive. This stuff doesn't typically react too much with the tissue around it, so it doesn't present as an erythematous inflammatory problem so much. It usually instead presents as just a pressure on adjacent tissues. So if it's in the vocal fold, it's pushing on the epithelium, or changing the shape of the glottic closure, which is going to cause the problem. In the larynx, it does occur more in men than in women, and typically at the peak incident age of 60 to 65. And the larynx is the most common site of head and neck involvement, more in the supraglottis than the glottis and the subglottis. And it's interesting that it's not typically involved when it appears in the larynx with any systemic disease. So again, this is often where amyloid will present primarily in the larynx, and this is our job to kind of figure this out. It can be associated with multiple myeloma, so good to get one of your colleagues to take a look into that. In fact, all of my patients even with isolated laryngeal disease, I'll have them see one of our specialists, myeloma specialists, to rule this out. This is what it can appear like here on the right. So these kind of tan yellow deposits, here it's in the supraglottis, that are, when you feel them in the operating room, they're firm, they're often yellow. They rarely cause stenosis or an inflammatory problem because, again, they kind of just are deposition rather than causing the tissue to react to it. Usually we don't engage in surgery on this, but we can. Certainly if it's on the vocal fold edge and you need to provide a straight vocal fold edge, or you need to get a diagnosis, we'll proceed with surgery on these folks. And unfortunately, there's usually not a good medical treatment, unless, of course, this is presenting with a myeloma, in which case there are good medical treatments for myeloma. All right, so I'm going to look at the question and answer. I don't see any new, so we'll move on. So we're going to move away from the cases now because we have about 20 minutes left to cover a lot of other stuff, and we're just going to talk a little bit about some other specific diagnoses in, again, these categories. So a little bit about polychondritis, and I am going to zoom through these pretty fast. Zoom, no pun intended. Relapsing polychondritis, rare in the larynx, certainly, and is rare in general. You can see here a picture with a lobule-sparing inflammation of the cartilage of the ear. This is where you have an autoimmune response specifically affecting the cartilage. And again, you have a lot of cartilage in the larynx, so it can present there. I'll skip a little bit of the background here. Often biopsy is not so helpful, and we really do go on history in these folks. For 15% of the patients have laryngeal or tracheal involvement at presentation. And eventually 50% of these patients will develop some sort of airway symptoms. Oftentimes that doesn't come through our clinic. It will go through the interventional pulmonologists who are treating their tracheobronchomalacia, but something important to consider. When it does result in this kind of malacia, you can have actually quite high mortality rates. So this should be managed early and aggressively by your rheumatology colleagues. Treatments certainly involve systemic steroids, dapsone, trachs and stents if it gets to that point. Here's a picture of one of my patients who came in with what I would describe as a atypical appearance for polychondritis, but he had the classic ear and actually nose inflammation and was diagnosed with an inflammatory process by a rheumatologist. You can see here, one of the things I want you to take away from this picture, just freeze this picture in your mind as a patient who has a need to see a rheumatologist. So when you see this kind of keyhole shape where the glottis, especially at the posterior aspect, forms this kind of keyhole or lens shape, I don't know what you want to call it, lenticular, I suppose, with some crusting, some inflammatory tissue here in the infraglottic region. You see this, you think rheumatology for sure. You think you likely need a biopsy at some point, and you think you might need to manage these patients with steroids, certainly oral steroids, but injected steroids can sometimes help. Note how it'll affect the voice, how there's thickening here of the infraglottic and glottic edge. Remember, those are the points where voice is really created, right there at the infraglottis at the mucosal upheaval point. So this patient's going to have significant symptoms. They may be coughing up crusts. They may have airway stenosis. This is the patient you need to be pretty aggressive about treating before this becomes a long-term problem. And again, this is not specific necessarily to polychondritis, but this is one of the ways that it can present. Certainly, I see a lot of patients like this with Wegener's, with IgG4 disease will come in with exactly the same laryngeal appearance, but you need to have a very high index of suspicion. This, my friends, is not LPR, not LPR. So keep that in mind. Let's move on to systemic lupus. So it's an autoimmune condition, as you all know, where circulating immune deposits or complexes deposits will go into various tissues, affecting vessels, connective tissue. We'll skip a little background here, but it tends to affect females. Here you can see a butterfly rash in this patient on the malar eminence. Presents with oral mucosal lesions, and many of these patients, 80%, present with head and neck manifestations. So we will see a fair amount of these patients with tracheal problems, with parotid enlargement, or with cranial neuropathies. Up to a third of patients, as Piku described in 95, will have laryngeal symptoms. Typically will present with hoarseness. In terms of what you'll find when you actually look, you'll see some vocal fold edema, rarely true vocal fold paralysis, lymphatic stenosis, nodules, things like that. Here's some pictures of the nodules, some ulceration. We're going to zoom through a few more of these things just so we can catch everything. Diagnosis is with some of the serologic testing. Again, remember that anti-double-stranded DNA is the most specific thing, and this may appear on some things like your in-service examinations. Treatments are typically with NSAIDs, steroids, long-term if you have vital organ involvement. Things like hydroxychloroquine, so the Plaquenil that you hear so much about in the news these days, can be helpful in preventing flares. And then for refractory things, you think about the more advanced immunosuppressant medications, methotrexate, mycophenolate. These are really the disease-modifying drugs in this case. Next, going back to this, we'll think about another immune problem, so that is Pemphigus or Pemphigoid, which is where you have autoantibodies to specific layers within the epithelium. Pemphigus, as you remember, is intraepithelial. That's this picture here on the left, whereas Pemphigoid is the subepithelial picture. So you can see this immunofluorescence of this kind of linear basement membrane picture on the right versus kind of just disseminated throughout the mucosa on the left. Does it really make a difference for our purposes, whether it's Pemphigus or Pemphigoid? No, not so much, but it's important to get a biopsy so you can help guide treatment because they have different prognoses, appear in different patient populations, and can have some different treatments. This is what they'll look like in the larynx. They tend to be supraglottic and pharyngeal in nature, but are rarely solely in the larynx. You'll see them again in the oral cavity and other parts of the body, the skin. Nikolsky sign, you remember this from your boards, perhaps. You have sloughing even with mild pressure. So it's often interesting when you do a biopsy on these patients in the office, you'll see some sloughing here, as you see in the bottom left picture. When you try to do a biopsy, this thing sometimes will just peel off, and that's because of that cleavage plane that's caused by the antibody effect here. All right, again, moving quickly, we would be remiss if we didn't talk about GPA and what's formerly known as Wegener's, which we now call granulomatosis with polyangiitis. As you all know, we don't call it Wegener's anymore because Wegener was associated with some bad things during World War II. So this is a systemic granulomatous disease. Again, we're talking about granulomas and how they can be very hard to diagnose, but this just tends to affect small vessels. And way back in the day, this was a fatal thing before we had good immunosuppressive techniques. Test for this is CAJA. Again, that's another important pearl to know for your boards and your in-service, which has a pretty high specificity for this. There are also other things like PR3, which we will routinely send as well, because that is also quite specific. And actually, the PR3 positive GPAs have different prognosis and different treatment options available to them. So say our rheumatologists, at least. Treatment revolves around corticosteroids. And again, if we don't treat these patients, they can have very high morbidity. But we can get most patients into remission now with systemic therapy. What does it look like in the larynx? Well, certainly we see subglottic stenosis commonly. So when you see a patient with Wegener's coming to your office who can't breathe, that's the presumed diagnosis for sure. You can see in the bottom CT image here, you can see very clearly the cricoid ring and soft tissue inside the cricoid ring. Remember, on a CT, you should not see soft tissue in the cricoid ring, certainly not to this degree. You may see a thin linear epithelial thing, but usually the CT will just show you cartilage and hair inside. When you see this, you know there's a problem. Biopsy is usually helpful, although usually required, but not usually helpful is what I meant to say, because it's not necessarily diagnostic. It's really the serologic testing, which is more helpful. And then some of these patients do require repeated dilation. Some patients end up getting end-to-end trach R&R for this. Mainstay, fortunately, is endoscopic treatment. Again, the open surgery has a high risk of anastomotic failure, and this is done by one of the groups that has the largest tracheal and subglottic stenosis population done from open surgery. I think they have something like 400 patients who've had open surgery, and they can say pretty consistently that they have good results, but the GPA patients have slightly worse results in general. All right, so we've talked about, in general, we're at 8:50. We've talked about all of these things to some degree, much less about the infectious and the bottom two things. On the top, we've kind of covered the immune, the deposition disease, and the granulomatous diseases. So I just want to cover a few key points then at this point. Laryngeal inflammation is nonspecific. It's important to remember that reflux can contribute, but really promise you, not all laryngology is reflux. And in fact, if you're looking closely enough, not a lot of it is reflux. It's important to remember that there is significant overlap between inflammatory diseases and that symptoms are mostly nonspecific as well. Remember that diagnosis can be aided by location. So we talked a lot about what is pharyngeal, what is supraglottic, what is glottic, and what is infraglottic. So think about amyloid, mainly at the glottic level, sarcoid, mainly supraglottic, pemphigus, often in the pharynx. Things like Wagner's are typically subglottic. So important to think about where you're seeing the site of disease. And then tracheous polychondritis. And this last point, involve your rheumatologist. I cannot emphasize that enough. Again, look at this picture on the right side of the screen. Look at that and think rheumatology. That's one of the things I want you to take away from this, because that's a very important thing. We cannot fix a lot of these things on our own. We can certainly manage some of the symptoms, but we really need help with systemic treatment. Remember also that the larynx can be a harbinger of systemic disease. It is often the presenting site for many of these conditions. So often we are the first line in kind of diagnosing these things, which honestly makes our job very interesting. There are some fields out there where you don't get to have really the true diagnostic process. I would say in laryngology, we are so fortunate to be able to really engage in that, and really no one else can tell the patient what's going on, and sometimes we are able to do that, and that's a very rewarding thing. Remember that a lot of the things, especially things like TB and then the deposition diseases, can mimic carcinoma. So high index of suspicion. Remember that carcinoma is more common than any one of these things in particular. So you got to keep that in mind. Medical therapy is the optimal treatment. I've harped on that enough, but surgery is helpful for diagnosis and to salvage the airway. And then we are kind of central in organizing multidisciplinary care for many of these patients. Lastly, at 8:52, I just want to give you a thanks for listening today. Laryngology, I hope you all know already, is a truly awesome field. We are diagnosticians, we are therapeutic, we are surgical, we are all of the things that you want to be, and can do it in the office, do it in the operating room, and I think we truly provide a lot of value. And so I hope some of the things that we talked about today kind of emphasize that point. If you ever have any questions about laryngology in general, about systemic diseases of the larynx, about any of the things we talked about today, please feel free to reach out. My email is right there below. And now I'll open it up to questions. If anyone wants to type anything into the question and answer area.
Matt, that was great. Thank you. That was a different take than I've ever heard on any laryngology, and it's wonderful.
Well, thank you, Brett. I appreciate it.
While we're waiting on questions, what got you interested in laryngology in the first place?
You know, it was during my pediatric rotation here at Mass Eye and Ear with a guy named Chris Hartnick, who does a lot of pediatric laryngology. And it was really the airway stuff that got me in initially. And then I started working with some of the laryngologists here and a lot of interesting pathology that we see here. And I really like the immediacy of everything. It's, you open the nose and you can pretty much give a patient an immediate diagnosis that not a lot of people can. That's really important. The immediacy of doing an injection in the office or procedures in the office. You know, I can see someone come into my clinic, diagnose them with the cancer, do a same day in-office biopsy with frozen, get that result back. And sometimes if it's like a carcinoma in situ or a dysplasia, you can even treat them on the same day. So you meet someone, diagnose someone, treat someone, send them home for a problem that otherwise might have taken months to work up. That's kind of what really excites me about this, is that we tend to have a lot of flexibility in the way we can diagnose and treat and help people in a pretty quick way.
That's awesome. It's a positive role model with some very immediate feedback from patients, so that's great.
Absolutely. Looks like no other questions at this point. Thank you, Dr. Yu. All right, well, thank you again, and you have my email if you ever want to reach out, okay?
Yep. Thank you again, Matt. We really appreciate you and the others at Harvard who are supporting this endeavor.
Absolutely, absolutely. Well, thank you.